Hey everybody, I'm Michele. I'm a licensed massage therapist in Washington State, and I bring you guys MBLEx resources. That's massage and bodywork licensing exam stuff. So here on YouTube, I have a bunch of videos, and then on my website, if you follow the link that's in the description and also in the pinned comments below, you're gonna find a huge list of tons of stuff that I have, practice tests, study guides, courses, all to lead you to getting through that massage and bodywork licensing exam with calm and confidence. Today, we're going to be going deeper into those connections between our nervous system and our musculoskeletal system, and we're going to learn specifically how to apply that in the treatment room. You're going to be getting questions about neuromuscular technique on your massage and bodywork licensing exam, so be sure to pay attention and watch through to the end of the video. Today, we're going to be talking about neuromuscular reflexes, that's reciprocal inhibition, the stretch reflex, the inverse stretch reflex. So we're definitely going to be going deeper into muscle spindles, and Golgi tendon organs and how they work. And what about gamma gain? I don't understand how that works. I'm going to go deeper into that, and hopefully I can explain it in a way that helps you to wrap your head around these abstract concepts. And then we're going to be talking about trigger and tender points, what they are or what people think they are, and how people find success in treating those on our clients. So if all of these concepts sound like topics that you need to know more about and you'd like some practice with the MBLEx questions that I'm going to be going over at the end of the video, then stick around to the end. Let's go ahead and get started. Okay, massage and the mind-body link. Working with the nervous system. So our nervous system is deeply connected to every layer of the body, from the skin that senses touch to the muscles that move us. In massage and bodywork, every stroke communicates through these networks, influencing tone, relaxation, and pain perception. Understanding how neuromuscular reflexes like the stretch reflex, reciprocal inhibition, gamma gain, and the inverse stretch reflex work help us treat more effectively, recognize trigger and tender points, and guide the body back toward balance and ease. Typically, in anatomy and physiology, each body system is taught as its own discrete entity, but in this webinar, we're integrating everything we've learned thus far to be useful in the treatment room. All right, here we go. So, neuromuscular reflexes. So, in the somatic system, the muscle is both the sense receptor and the motor effector responding to a nervous system command. So the muscle is getting these messages, and it's getting the information. Like you go to pick something up and it's hot, and it sends that sensory information up to the spinal cord. There's an interneuron. So there's one neuron that's the sensory neuron, and then there's a neuron in the middle that's the interneuron, and it's making a decision. Its decision is drop that hot thing, and then the command goes down for you to respond by dropping it. Or I think that's a good one. Okay, so that's what a reflex is. It follows this pattern where it goes sensory information in, a decision is made, and a motor command goes down. So real quick, we're going to revisit these movement terms that we went over in the kinesiology section, because that's going to help us with some of these reflexes. So we've got the agonist, which is the prime mover. Let's say, for example, the agonist that we're going to talk about is the bicep brachii when it comes to elbow flexion. So flexing your elbow. Boop, 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 boop. The antagonist would be the oppositional muscle, and that would be triceps brachii. And a synergist would be a muscle that helps with muscle or elbow flexion, and that would be the brachioradialis or the brachialis. Also, another thing that to keep in mind with antagonists like the tricep brachii is that it does the opposite movement. It's the agonist in the opposite movement, which is elbow extension. So when we're talking about reciprocal inhibition, we're talking about how the reciprocal muscle, which is the antagonist of the movement you're trying to do, has to be inhibited so it doesn't contract and you don't end up just not doing anything. So let's say, for example, you want to flex your elbow, then that means that at the same time that your spinal cord or your central nervous system is telling you to flex that elbow, at the same time it's telling you to flex, it's also telling the triceps not to contract. So it's inhibiting it. So this guy's like, his central nervous system in his brain is like, I want to curl these weights. So his bicep is contracting, and at the same time his tricep is being forced to relax. Now, also the antagonist is not going to be fully inhibited, because when he's lowering, so he lifts and then he goes to lower the weight down, we need to see how his tricep kind of flexes a little bit back there. It's because he is not isometrically, he's eccentrically lowering that weight with his antagonist muscle. So we do need to have not a complete inhibition, but just a careful switch. So that's how that works. Now, when it comes to using the concept of reciprocal inhibition in your practice, let's say, for example, a client has a cramp in their calf. That has happened to me quite a few times when I've had a person on the massage table. Something happens in the chemistry when people are getting a massage is that they're more likely to get a cramp at a different part of their body when they're getting a massage. So that's really interesting. We'll talk about that a little bit more in a minute. But so they've got a cramp in their calf, and so the therapist is like, all right, well, let's get on it now. And they say, I need you to contract the antagonist muscle of this cramping muscle. So what's the antagonist of the gastrocnemius or the soleus? That would be the tibialis anterior muscle. So we want to get them to dorsiflex their foot, so that dorsiflex their ankle, so that when this is contracted, their reflex is to inhibit that calf muscle, and it can help to relieve the cramp a lot quicker than if you just let it run its course. So yeah, encourage the client to engage the antagonist muscle, and then at the same time gently try to stretch, especially after the cramp has run its course and it's still like feeling bad. Gentle stretches. So this is what the neuromuscular technique is called: contract, relax, antagonist, contract. So if they don't have a cramp, let's say they have just a resting tone on their calf that's higher than it should be, and they're like, oh, it's keeping me from getting my full range of motion in my plantar and dorsiflexion. So what you would do is you would encourage them to contract that calf muscle by plantar flexing their ankle. So putting their foot down on the gas, that would contract the gastrocnemius, but not a hard contraction, just a little bit of a gentle contraction. And then you can also resist that foot so that, or resist that movement so that they have a little bit of something to engage. I just say, just engage it a little bit, right? Just a tiny, tiny bit. And then they would release it. So that's contract, relax. And then you would follow up by saying, go ahead and contract the opposite muscle, have them contract their tibialis anterior muscle by doing a dorsiflexion, and at the same time stretch that gastroc that you're trying to engage or trying to get the tone down on. So that's how contract, relax, antagonist, contract works. That is a neuromuscular technique. So now we're going to go on to talking about the stretch reflex. So once again, we have that reflex loop, right? Sensory information goes in, motor command goes out, and there's an interneuron in the middle. Now, in the stretch reflex, there is a specific proprioceptor, mechanoreceptor, in the muscle tissue that's called the muscle spindle, and it monitors how much your muscle stretches. If it's stretching too much or if it's stretching too fast, that muscle spindle kicks into gear and it contracts the muscle and prevents it from stretching anymore. All right, so I just want to explain intrafusal versus extrafusal fibers in case that comes up on the MBLEx for you. The intrafusal fibers, when it comes to muscle spindles, are the fibers that are inside of the muscle spindle, because the muscle spindle is inside of its own connective tissue packet inside of the muscle. So the intrafusal fibers are going to be inside of the muscle spindle packet. The extrafusal fibers are going to be the muscles that are affected by the motor command. Okay, so they're the actual contractile muscle tissue are the extrafusal fibers. Really easy. So the muscle stretches, goes too much, too fast. The spindle's like, oh, no, you better stop. And it sends that message to the reflex arc. The interneuron says, tell it to stop. And so the command goes down to the extrafusal fibers, and the muscle says, nope, not going to stretch. And when people have situations where their muscles are hypertonic, often it's because that muscle spindle has clenched up. It's not working the way that it should. Now, when we're going to go a little bit deeper beyond the simple stretch reflex and the muscle spindles to understand how things get out of hand when it comes to the contracting part of the muscle spindle. So gamma loop is another layer of information and motor commands in addition to just what the muscle spindle is doing on the surface. There are additional fibers, nervous system fibers, that are called gamma neurons, and they are also coiled inside of the muscle spindle, and they pick up information about how fast that spindle is stretching, how much, and also it gets information from the environment about what you need to be tensed up about, what you need to be worried about, what you need to be on edge about, so that you can clench your muscles easily. So it gets information, sends it up to that interneuron in the spinal cord, and then it takes that information and commands to contract the muscle spindle so the muscle spindle is even more sensitive to any kind of stretch. So it will clamp down the spindle to keep it from being able to stretch in the first place. So the more gamma information that you're getting, the tighter that muscle spindle is going to be, the less likely it's going to want to stretch, the more likely it's going to clamp down. So it increases the sensitivity of the muscle spindle. So here's a little demonstration once again. Information comes in from the spindle, goes to the interneuron, comes back down, and the fibers, it's completely in the intrafusal fibers. So the command neuron the motor neuron is entwined around the muscle spindle, not the extrafusal fibers. So it completely commands the spindle. So referring to gamma gain, that is how likely that muscle spindle is to be sensitive. The more gamma gain you have, the more likely it is that your muscle spindle is going to be sensitive. So if you have lower gamma gain, that means you're laid back, you're relaxed, you have no threats around you. And then like in an individual muscle, that means that the muscle is healthy and relaxed. And so the muscle spindle has like a lower or maybe a higher threshold to handling any kind of stress. Let's see. Yes. So gamma gain intensifiers. What can intensify gamma gain and make your muscle spindles more sensitive would be things like emotional stress or sudden lengthening, cold temperatures, pain or injury, repetitive movements, postural habits, fatigue, or any kind of neurological conditions like cerebral palsy. Those are conditions that will make your muscles more prone to freaking out and contracting. Okay, so we're going to talk about trigger points and tender points a little bit. So what is a trigger point? It's a hyper-irritable spot in a tight band of muscle that is tender when pressed and can refer pain to distant areas of the body. And it's been charted by a few different researchers that there are specific spots or general areas that you can compress, and it will often trigger a referral point. So when you look at these charts, typically it's like dots. Some of them have like big bubbles. I have one with like a big bubble, a chart like that in my massage room of like general areas where you're going to feel the sensation. But some guy like went through and did a bunch of research on his clients and charted everywhere that a little dot is the place where they felt the sensation when he compressed that trigger point spot. So that's what a trigger point would be. A tender point is also a hyper irritable spot in a tight band of muscle, usually. Sometimes it's silent. Sometimes people don't feel the tension in it. Sometimes people don't feel the pain in it. And there typically isn't a referral pattern. So in the past, these two have differentiated that they were very different. But I know from my own experience, and also like generally research is kind of questioning how to differentiate between the two, because different people have different ways of experiencing sensation in their bodies. And so you can infer that the sensation that they're feeling is a trigger point or a tender point based on your own biases as a researcher or as a massage therapist. And then add to that another layer of the client having their own experience of their sensation and not being able to articulate what they're sensing. It kind of blurs the boundaries between these two. And so when you're approaching trigger points or tender points, try to be open-minded that it can be both or neither. It can just be a hypertense spot that has referral patterns, but it's not going to be, you're not going to have success. You might not have success doing trigger point therapy. But what I'm going to do is I'm going to talk about what created each of these according to some of the theories in the past and how to treat them from the angle of each of these two being discrete symptom disorders, right? Musculoskeletal disorders. Just for the sake of you being able to understand it in case you get an MBLEx question about it. So tender points are the ones that typically don't refer, and sometimes can just be a sensitive spot when you touch it. Possibly they're caused by too much gamma gain in the muscle spindle. So that gamma gain is like the muscle spindle is already sensitive because it's a muscle that they're using a lot because they're doing a lot of like labor, or they're keeping their shoulders crunched up when they're working at their desk. I just want to mention that you're hearing like a lot of noises in the background. If you are, it's because I have a new kitten and she is nuts. So when you hear thrashing and crashing and little meows, it's a little baby kitten running around my living room. Okay, back to what I was talking about. Muscle spindles, sensitive and hyperactive. And so a treatment that we do, it's called positional release therapy or strain counter strain. They're the same thing, where there is a muscle that is strained. So let's say this gentleman is having symptoms of having a lot of tightness in his hip flexors, and it's very sensitive when the therapist touches it. So what the therapist is going to do is she's going to put that hip into extreme flexion, going, within the client's comfort zone. And she's going to hold that position for at least 90 seconds or until like she's touching that spot and they're feeling less sensation. So this is the gold star standard therapy for someone who is experiencing a hypertonic muscle that it appears that the muscle spindles are hyperactive. I use this technique a lot on people because it's gentle, and as opposed to just grinding away at muscles, just smashing the heck out of them just to increase blood flow. Yeah, especially on those sensitive ones, your client is going to go into fight or flight, into the sympathetic stream, and that's not what we're going for as therapists. So it's just an awesome technique to use on people that have very sensitive hypertonic muscles. Now, trigger points, we don't do this. I want to make that clear. We do not do dry needling as massage therapists unless you have some other kind of certification that enables you to be able to do that. But that has been a treatment for trigger point therapies in the past, is that people will put a needle into the muscle tissue to interrupt that cycle of spasming and pain that is happening and the referral patterns that are happening. And it is a therapy also, like using ice, deep ice on that spot. Some people have like an ice spray. Physical therapists have an ice spray that they use, and then they like use deep pressure on it to break that up. So, we don't do that, but it is something that can be done. So, possible causes. Motor end plate dysfunction. Now, we talked about motor end plates in our unit on muscle contractions, so make sure and check that out if you haven't already. A motor end plate is the end of a motor neuron that sends out neurotransmitters, specifically acetylcholine, that is picked up by the sarcomere of the myofibrils and releases calcium into the sarcomeres so that they can contract. So that's like the healthy way that it happens. But if there's a dysfunction in that motor end plate that makes too much acetylcholine come out, it makes too much calcium come out, especially if the motor end plate is not connecting with all of the muscle fibers. It can cause some of the sarcomeres to become locked, and so there's not enough ATP to unlock them. So actin and myosin are locked when ATP is used up. So this is a theory. We don't know, but it's a theory that people have come up with that could be the case. So contributing factors for a trigger point, pretty much anything. Overload stress, injury to the muscle, muscle fatigue, repetitive use, underuse of muscles, malnutrition, stressful lifestyle, drug addictions, ingesting things that you should not be ingesting food-wise, allergies. Anything can cause a trigger point. So, anything that's going to cause those motor end plates to not work the way that they should. So, treatments for body workers. This is the chart that I have in my massage room. So, like it'll have like a little dot on the place where you use the compression, where you press in. See how this therapist is not really using the best technique, using their thumb like that, but it is something, if it's a delicate structure that you're working on, specifically on the neck. But I typically, in a place like that, I would use a knuckle in there, or I would use an elbow, a gentle elbow in that space, so that I save the ligaments in my thumbs. But anyway, so you press on the spot that's indicated, or right around the area that's indicated, and you'll ask the client what sensation they're having. They're like, whoa, I feel that all the way up. Let's say, for example, you do a compression in the levator scapula there, and they're like, oh my gosh, I feel that all the way up around my head. And you will memorize these patterns. You'll notice these trends that researcher did notice when he created these charts. You'll notice these trends too, and what you would say is, okay, so I want that sensation to be at like 5 out of 10 max. I want you to be able to totally relax through it, because the point is that your nervous system needs to feel like you're safe, so that it stops freaking out and reacting to the sensation that's going on in there. So yeah, I tell them we want to keep it between a 5 out of 10. What number am I at here? You get their feedback, ask them about the sensation so they're mindful of that, and say, I'm going to hold this for 90 seconds or 2 or 3 minutes. Sometimes you might have to hold it longer. I've heard of some incredible times that people have held trigger points to release them. But yeah, I just check in like a minute and a half to 3 minutes. I'm like, any change in that sensation? And if they're like, yeah, it's softened up, then that means you've come a long way toward releasing that trigger point. And if they're like, it's the same, then I go back to that contract relax. I don't keep smashing that trigger point. I try other things. Basically, you want to throw everything at the wall when it comes to treating trigger points and tender points, because you're not sure whether it's a trigger point or a tender point. They overlap in symptoms. So yeah, here's a list of how trigger point treatment works. That's it, specifically the compression of the trigger point. So there's temporary blood flow restriction when you press on the spot, the hyperirritable spot. And so it reduces the abnormal electrical activity at the motor end plate. That's the theory. And then neurological feedback reset, inhibition of the muscle fibers through sensory information about the stimulus being present but not harmful. So there's like a reset where I talked about adaptation in the nervous system videos, where your body becomes desensitized to the sensory information coming in from the compression that you're doing. And so there's like this reset of what your body thinks it needs to pay attention to. And then the reactive hyperemia, when you let go of the trigger point, is that blood flow rushes in, increasing circulation, which reduces that motor end plate dysfunction. So the nervous system adapts to the continuous non-dangerous signals from the trigger point compression. So yeah, and sometimes I will release a trigger point and it's successful using compressive techniques. The client will come back within a week or two and that trigger point's back, but it's not as bad. And so I just keep working on it every time, and they're like, it's getting better, and it's getting better. So I have had success doing it that way. But I've also had success trying other techniques, throwing those in there too. So when in doubt, try treating these symptoms from both angles, okay? All right, so moving on to talking about the Golgi tendon organs and the inverse stretch reflex. So Golgi tendon organs, which is not the same thing as the Golgi apparatus. I talked about this. They're just both named after the same guy. They're totally different. Okay, so the Golgi tendon organ is a sensory receptor that goes up, the information goes up from the tendon, or actually the musculotendinous junction, to be specific, goes up to the spinal cord, interneuron, makes sense of the information, and communicates down to the muscle fibers to relax. It allows the muscles to stretch. And the reason that we have this reflex is that sometimes we want to pick up something that's way too heavy for us, and that will snap the muscle off of the bone. And that's what happened with this guy. He tore the muscle to the point that there was a contusion on his arm right there. He was curling his weights and he went a little too far. The Golgi tendon organ didn't do its job. So its job is to keep you from being able to contract that muscle. So sometimes you go to lift something and your muscle will just give up. That's the inverse stretch reflex. Now we can use that to our advantage, but we have to keep in mind that active muscle contraction is what stimulates the GTOs, not just increase in tension in the tendon alone. So, how do we use GTO stimulation in our treatments? So, first of all, be sure that the client is out of any kind of acute healing stage for the target muscle that you're working on. So, some guy's like, oh, it hurts in here, and they got a huge contusion. You're not going to be doing this technique. I mean, you're not going to be massaging that area at all. But just, watch out for that first. Focus on slowly, gradually increasing tension in the target muscle. So this is great for hypertonic muscles and treating tension with no sign of trigger point or tender points. So someone just has chronic tension between their shoulder blades. So, and just like increasing blood flow through a moderate petrissage isn't doing the job. So what I'm going to do is I'm going to work along the musculotendinous junction of the rhomboids. So where the tendon attaches to the bone and where the muscle attaches to the tendon, I'm going to go find that spot. So it's close to the bone, but just kind of right off of it. And I'm going to put a moderate compression on that area. And then I'm going to tell the client to gently engage the muscle. So, 2 or 3 out of 10 in how much contraction they could possibly do. Just gently engage it. Have them hold it for 10 seconds. Have them release it. Do it again. Do it like 3 times. And then ask them, how's it feeling now? Does it feel less tense? You can feel for yourself. I can actually feel the change as it happens. Sometimes I'll be like, okay, I'm going to release that, work on the low back, come back to that rhomboids. And in that time, the GTOs have done their job instigating this reflex. And the tension, the tonicity in the rhomboids has released to the point where I can feel the shape of their scapula. So that is pretty awesome. That's what's called contract relax, okay? And then contract relax, antagonist contract, that's also encouraging reciprocal inhibition at the same time. So someone has hypertonic ESGs, the erector spinae group, those are the muscles running up the paraspinal, so right along the vertebrae all the way up. So somebody's got increased circulation in that area. Increased tonicity in that area. So what I will do is I will use compression along the iliac crest where that musculotendinous junction is. So a moderate compression in that area. And then I will have them first try to lift their chest off the table very gently, just a little bit, have them do that 3 times. Then I have them release, and then I have them crunch their abdominals and bring their shoulders, curl their shoulders forward. Have them do that 3 times. That's going to go a long way toward those Golgi tendon organs being stimulated in the erector spinae group and causing a release of those contractile fibers in the erector spinae muscles. It is magic, really. So cool. So let's do some MBLEx-style questions now that we got all that information out. Got some great ideas for treatment that is less challenging and painful and a lot easier on your body. So let's go ahead. The stretch reflex is triggered by activation of which sensory receptor? Stretch reflex. So let's remember, Golgi tendon organs. A, Golgi tendon organs. That is the inverse stretch reflex. B, Meissner's corpuscles. Meissner's corpuscles are a integumentary system, sensory receptors for light touch. They live more on the surface, very close to the epidermal layer. Muscle spindles, those are what cause the stretch reflex. That's C. And then D would be Pacinian or Pacinian corpuscles, and those are for deep compression or deep tissue because they live deeper in the dermis. So yeah, C, muscle spindles would be the correct answer. Muscle spindles are specialized sensory receptors within skeletal muscle fibers that detect changes in length and the speed of stretch. When they sense a rapid elongation, they trigger an immediate reflex contraction to prevent potential injury from overstretching. The other options are incorrect because Golgi tendon organs, A, respond to tension rather than stretch and cause relaxation. Meissner's corpuscles, B, detect light touch in the skin, and Pacinian corpuscles, D, respond to deep pressure and vibration, not muscle stretch. Next question. A client's neck and shoulders feel guarded and reactive during a massage. This most likely reflects, so let's look at the question. Neck and shoulders feel guarded and reactive. Okay, so A, you'll find that a lot in your clients. A, low gamma gain and full relaxation. I would not say that. B, elevated gamma gain and muscle spindle sensitivity. That sounds good. And C, inverse stretch reflex activation. That means relaxation, right? That's what Golgi tendons do, or Golgi tendon organs do. And D, post-isometric relaxation response. So that would be kind of like the contract-relax response of the inverse stretch reflex. So no. So B, elevated gamma gain and muscle spindle sensitivity would be the correct answer. When gamma gain is high, the muscle spindles become overly sensitive to stretch, leading to constant low-level contraction and the guarded, tense feeling therapists often notice when in stressed clients. This heightened sensitivity is common with emotional stress, cold, pain, or chronic postural strain. The other options are incorrect because low gamma gain, A, produces relaxation rather than tension. Inverse stretch reflex, C, causes relaxation through Golgi tendon organ activation. And D, post-isometric relaxation, follows a voluntary contraction, not passive guarding. Next question. A massage therapist asks a client to contract the quadriceps while relaxing the hamstrings during a stretch. Which reflex is being utilized? A, reciprocal inhibition. B, stretch reflex. C, inverse stretch reflex. And D, gamma gain. Let's look at the question again. Contract the quadriceps while relaxing the hamstrings. So if we're trying to relax the hamstrings, then that means they're being inhibited, right? So I would go with gamma gain is not as, well, it is a reflex. They're all reflexes. But I'm going to go with reciprocal inhibition because the hamstrings is an antagonist to the quadriceps. Yay! Reciprocal inhibition is a spinal reflex that allows coordinated movement between opposing muscle groups. The other options are incorrect because the stretch reflex, B, causes contraction of a muscle when it's rapidly lengthened. C, the inverse stretch reflex involves relaxation in response to excessive tension detected by the Golgi tendon organs. And gamma gain, D, refers to the nervous system's control over muscle spindle sensitivity, not the coordinated relaxation of opposing muscles. Okay, last question. What is one accepted theory about the cause of a trigger point in muscle tissue? Okay, because people are going to ask, what causes this? I've had to explain it to people what the theory is many, many times. So, A, lack of calcium in the bloodstream. I don't think that's correct because remember we were talking about how the theory is that there's too much calcium in the sarcomere. So that's not it. B, excessive acetylcholine release at the motor end plate, which would be the cause of too much calcium in the sarcomere. So that would be a thumbs up answer. And then C, compression of a nearby nerve root. No. And then D, overstretching of the connective tissue sheath. So those are not correct. Okay, B, excessive acetylcholine release at the motor end plate. Trigger points are thought to form when motor end plates release too much acetylcholine, keeping a small group of muscle fibers in a constant contracted state. This creates local ischemia, that means lack of blood flow, and pain sensitivity. The other options are incorrect because calcium imbalance, A, and nerve root compression, C, relate to broader physiological issues, and connective tissue overstretching, D, affects fascia, not motor end plates. And that concludes another section of anatomy and physiology. So I hope you guys got a lot of great information from this about how to treat your clients and also great information about how to answer those massage and bodywork licensing exam questions. If you love this video, make sure and subscribe and give the video a thumbs up so that you can be in the loop about future videos and also so that you can promote this video so that other future massage therapists have access to this information. And with that, I will see you in the next video. Toodaloo!